We will go ahead and get started. Good morning, everyone. Thank you for joining us. My name is Joshua Davis. I'm on the SI team at the Office of HIV/AIDS at USAID, and I'm joined here with my colleague Latham Avery, who is also a data analyst. And we are delighted to be with you today to present three great presentations from some of our partners. We're going to kick off with Professor Pedro T. Pisa, who's the Chief Strategic Information Officer at the Right to Care Group. And we're going to go ahead and let him get started. So we've got two presentations after that. And we are going to save time at the end for questions and hopefully some good discussion. At the end, we'll be able to open the line up for people to ask questions on the line, but also at any point during the conversation, please feel free to type your questions into the chat box and we will address those during the discussion session. Thank you very much, and I'll hand it over to Professor Pisa.
Thank you. I think I'm unmuted now. The presentation is more on some examples on how in Right to Care we have used particular innovations to improve data utilization and provide near to real-time data to our programs so that we can have more precision programming and targeted programming within our programs. So we are in the business of providing care and treatment across the HIV spectrum and TB spectrum. And the innovations that I'm going to present now, we use them in South Africa and all the other areas where we are a DSP and running DSD programs. For example, through EQUIP in Zambia, we use the same approach and methodology. What we did through our tech partners, Code, we developed what we call the Knowledge Center Hub. And basically the Knowledge Center is a centralized warehouse that has all data that's submitted housed on Microsoft Azure, which actually has cloud security protocols and all security protocols to make sure that data is safe and it complies to IT governance and complies to all international standards for patient-level data and aggregated data. And with this Knowledge Center warehouse, you actually can view the performance based on the targets that you set for each facility on a daily basis or weekly basis from wherever you are, if we give you access to the programmatic data that we manage through the DSD program. So we have always seen a gap in a sense that when you actually report for datum or our high frequency reporting or do Department of Health reports, or we try to do the DHIS reporting, we have actually anticipated that at times we are actually too late. We report on a monthly basis, on a quarterly basis, but when you actually get to understand the performance of your program, there is not much you can do in reverse. And you actually see that there are specific indicators that are tracking, but it's already time for reporting and you can't reverse that. So what we have done through this system, we've actually powered what we call daily situation room reviews across all our programs. But in these review forums, we've actually included us as the implementing partner, key DOH specific people, and at times our USAID colleagues, so that on a daily or weekly basis, they know where we are in terms of performance for key indicators across our programs. Then what we actually do with the system, we have customized the analytics and visualizations, first based on the May guidelines that we get from USAID, but also we know that we also need to report to the Department of Health, and we need to report on high frequency reporting. So in terms of enhanced reporting efficiencies, we've actually customized the backend so that when data is fed into the system, it automatically gives you the output and the report that you actually need on a daily basis, because we report certain indicators on a daily basis to our USID office in South Africa, and on a weekly basis, and actually for the high frequency reporting and data. So I'll demonstrate shortly how data availability in near to real time and using situation rooms or data review methodology to actually set targeted interventions in a differentiated fashion. Because you see that the challenges that are in a particular district are not the same as the challenges in a particular district. The indicators that are struggling in one district are also not different to another district. So the amount of energy that you actually need to spend on particular intervention is actually differentiated based on the actual data. Then this is just a quick to just show you that is right to K in South Africa. We look after 2 districts, Ehlanzeni and Thabo M. Ehlanzeni is in Mpumalanga province, and Thabo M is in the Free State. But for easy assimilation, I just use the data from Ehlanzeni as the guideline to what I'm trying to illustrate. So what we developed here, it's an automated data collection system where on a daily basis, we actually can track the key indicators at every facility. For example, in Ehlanzeni, we actually look after 137 facilities. So on a daily basis, an email template is actually sent in an automated fashion. An M&E officer captures the data on this data collection form in an aggregated fashion, disaggregated by age, by sex, and by different modalities. And when I mean modality, I actually mean that, for example, if you've got 10 people that are initiated at a facility, what are their entry points in a facility? Is it TB entry, for example? Is it outpatient? Is it maternal entry? So this helps us in actually augmenting our staff to understanding that, you know what, all your new cases are predominantly coming from TB entry, for example. But these things are different for each facility. So you need to actually augment your facility based on the data that you actually have. This, after the M&E officer completes it, they just press the enter button through email. Then this is sent onto the knowledge center, which I told you that it's a warehousing platform hosted on Azure. And when it gets in there, already in the back end, we've got automated reports and dashboards that come out of this. And the visuals become available to everyone that's registered on this. And this includes the district teams, provincial teams, the implementing partners, and key USID people, so that we are all seeing the same data on a daily basis to actually help each other to augment our program in the areas that actually need support, that are doing badly, and that are doing well. And from the EMR system, which we call TIER in South Africa, we struggle with modality data, and this platform actually is the platform that actually helps us with actually giving us key modality data for each facility. Next slide. Next slide. All right, so I'll speak as they try to roll out the next slide. But the key thing on this is the centralized warehousing is safe and complies to all international standards for data safety. Rhoda, can you move the slide to the next slide? Sorry, thank you. So like I'd mentioned that the gold standard to our validation of your data is actually not what's on the knowledge center. The knowledge center is a process. It's what's actually on your EMR system. So what it then does, it's on a weekly basis, we run the dispatches that are actually on the EMR system to actually see for each facility what the indicators look like. We compare that with what's on the knowledge center, and this will give us a clear indication to the gaps of capturing as a QA, QC process. So you actually see that, you know what, based on our data from the knowledge center, as an example, we initiated 10 people at my facility every day until Friday. So we anticipate that we've got 50 people coming from our facility as TX new. But when you run in the EMR system, you actually see, oh no, we've got 30 people that's on the EMR system it then tells you that there are 20 files that are out there that have not yet been captured on the tier system. Then it initiates and activates some intervention with the M&E teams to sweep the facilities, look for these files, make sure they're actually captured on the EMR system, because our auditing is based on the EMR system and not the knowledge center. But it helps as, because if we did not have that, you do not have an surveillance or a view of what's actually happening across our 136 facilities on a daily basis. So our chief of party runs this situation room every day at 7 o'clock to 8 o'clock, an hour every day across the key facilities on a rotation format so that we are aligned on the key activities that need to be done in that week based on where we are and what the situation rooms are actually telling us around our data. Next slide. Next slide, Rhoda. All right. So as Rhoda tries to give us the next slide, so we have talked about you're going up, not down. Go down. Down again. You're going up. Go right. Thank you. Next slide. Next slide. Next slide. On that slide. So wait on that slide. Sorry, on that slide. So I've told you about the knowledge center and the ADC that relates to our M&E teams submitting data. What we also have, it's what we call the point of care ML solution, called the links health solution. This relates to our counselors and not our M&E teams. What we do that this is an app, Android compatible, and syncs directly onto our knowledge center. It geolocates where the actual testing is actually happened. So this tool is used by the counselors that actually do the counseling for every test that's actually performed. So it's done predominantly within key entry points, but also is done for all community testing that we do. So with the geolocator and the outcomes that actually come out of it, it gives you data in real time. So it actually helps you to actually understand the areas where you need to focus on, the new hotspots that you actually based on the geolocator and where your positives are coming. So this has actually helped us to improve our case finding over time. And also it gives you data at a patient level and it's POPI compliant, but it also gives you the modality data as well. So from this tool and the ADC tool, you can actually compare and do a verification to actually see, you know what, in this district, the people giving me the main new HIV positive cases, are they coming from the same modality? If you use the links health, and when we capture data on the ADC as a validation process, but this has worked well for us. We're not the only partners that actually use the solutions. We know that other DSPs in South Africa are also using links and they're using the knowledge center. So this is our key innovation when it comes to community screening and testing and using and improving case finding using data-driven approaches. Next slide. So another key thing that's a challenge, which also brings out opportunities. It's TA is more or less our EMR system for HIV, and the National Health Laboratory Service is the laboratory-related outcomes. Syncs talks to more of pharmaceutical data, and the Links Health actually talks to the counselors in screening and testing of HIV data, and the automated data collection is more aggregated data that's actually captured on a daily basis, and at the back end added together to give you a weekly or a monthly picture, and we use that to validate what's on the EMR system. However, as we start exploring big data and analytics and having a bigger step forward in actually creating key evaluation questions and analyzing data, the integration of the different data sources is key. And through the knowledge center and backend algorithms within our 2 districts, we actually managed to integrate the tier data and the NHLS data to actually give us one long longitudinal record. And I'll explain later, we've actually used this to actually answer key questions around who's most likely going to default, who's most likely going to be unsuppressed, and we've actually created data for action frameworks related to what actually has to happen in a facility and profiling patients, though in a de-identified format, patients to actually give that first line intervention through our technical teams to who's most likely going to default or not default based on predictive modeling and value-add analytics. Next slide. So this more or less reiterates to the need of adding other data sources, not just TA and the lab data, but to actually add additional pharmaceutical data and other related data that can actually be integrated. The algorithm matches and integrates by use of name, surname, nickname, gender, where one was initiated and the likes, and it's refined. But at the moment, its specificity is higher than 89% when it comes to matching. Next slide. So this is just an illustration as a case where we actually proved the concept that running daily situation rooms and weekly situation rooms, not just as an implementing partner, but together with the Department of Health teams in using data-driven interventions and systems as a way of improving your data utilization, actually helped us when we ran what we called the Cienza intervention. So the Cienza intervention was when USAID in FY20 gave us a time frame over 2 months and selected specific facilities that were struggling, and we're tracking these facilities on a daily basis to make sure that they come out of the red and into the green. And a key innovation for us was data availability and utilization together with DOH and running situation rooms. That was the key intervention we did. Of course, this is from an SI point of view, but the SI and the data thing led to the interventions. For example, where do we need to have our counselors? Where do we need to augment staff? Where do we need based on the data that we had? Next slide. So after the Cienza period or the Cienza project run by USAID and the use of the Knowledge Center in daily performance reviews, we saw at the end time a 6% increase in our TX car from baseline. We had a 35% increase in CAFS finding or TXU, and we had a 30% increase in our retention ratio, which was very important. And since then, we have scaled up these approaches across to our Zambian programs. They also use the Knowledge Center and the Situation Rooms approach together with the Ministry of Health there. And this has worked well. And it's an innovation that we have since scaled up across all our programs. Next slide. So this is a slide, so I'll end here. This is a slide that just shows the type of value-add analytics we can do through the integration of data from different systems at patient level. So, I mean, we're able to create response for patients, for targeted interventions, for defaulting. You can determine what factors are influencing that defaulting and change them as an example. So this is just an example. And with this analysis, we actually partnered with the University of Wits, which is HERO, and Boston University on supporting the actual analytics and analysis so that we can actually do the predictive modeling correctly. But the key thing is here, it's actually the actions and the interventions that we actually had to actually integrate within the program to actually improve retention. This has been going on well, and we're trying to modify our approach in recent times due to the COVID pandemic, because that has also hit a bit of our numbers due to a decrease in headcounts and people coming to the facilities, especially on the level 5 when it was really a hard lockdown. But value add analytics was a game changer in terms of our retention prior to COVID. Next slide. So I think I'll end with this slide. It's a reiteration of the Knowledge Center and how it powers situation rooms and the outcomes of what it can actually generate on the right, which is your greens, and a transition of data-driven interventions by having near to real-time data from multiple sources being available to the program is the key highlight. And this actually provides the great efficiencies in reporting, high frequency reporting, data submission, QA, QC processes, but ultimately improving care and treatment outcomes for our patients, of which that's the key outcome for our programming. I'll pause there.
Great. Thank you very much, Professor Pisa. Again, as I said, for the running order, what we're going to do is jump to the next presentation, which is from Emmanuel Mpinga. And please do either type your questions in the chat box or hold them to the end. And we're gonna have question and discussion at the end to try to thematically unite these different presentations. But thank you very much, Professor Pisa. Hopefully the power situation will allow you to stay with us. So next is Emmanuel Mpinga, who is a database manager with FHI 360 Tanzania. Thank you. Emmanuel, over to you.
Yeah, thank you, everyone. On the screen, I would like to present mobile data collection technology in remote site, which is in Ruvuma during COVID-19. Next slide, please. Just to give you a background on our program, this is USAID Boresha Afya Southern Zone. It's a 5 years program which started in 2016 and it's expecting to end in 2021. Our funding areas, PEFA, MCH, family planning, TB malaria initiative through USAID. The program also ran in as a consortium with Deloitte Consulting as a prime and FH 360 in gender health and management development health. Our goal is to improve lives of Tanzania. And also part of our vision is to create dynamic and integrated platform in order to deliver health service to Tanzania. We also collaborate with the government health facilities and other institutions. Next slide, and communities. Next slide. So as I stated earlier, this is a consortium project. We work with Deloitte as a prime. Deloitte also provide overall strategic direction, project management. We do have also another partner or IP, which is in gender health, which is a lead in family planning, HIV, maternal, newborn and child health integration. We do also other partner, which also I'm part of it, which is FHI 360, which also is a lead, technical lead in HIV, TB, malaria, and yes, and malaria. And also we do have MDH, which is a lead implementing partner in terms of HIV, TB, and malaria. Next slide. This is our program coverage area. As I stated earlier, we operate in 6 regions, which is Iringa, Njombe, Ruvuma, and Mtwara, Lindi, and Morogoro. And as you can see, each region has a thematic area that we are implementing. For example, in Iringa, we implementing HIV, TB, family planning, and MCH. In Lindi also, we have HIV, TB, family planning, and malaria. And also Morogoro, which is HIV, TB, family planning, malaria, Njombe, and also we do have Ruvuma, which is we're implementing malaria and HIV. Next slide, please. So the purpose of this, the key point that I want to highlight is the rationale on developing the mobile data application in order to support its 618 sites in our 6 regions. We saw the need to have a mobile data collection solution in order to meet PEPFAR reporting requirements due to COVID-19 pandemic. And also we wanted to ensure that PEPFAR guidance is observed, which is physical limiting on facility visits. And also the program identify and develop mobile solution, which is quick to customize and deploy. And also the solution which we intend to use, which has a catching mechanism, which can operate both online and offline site. The mobile application is also being used by data clerk to support this facility to collect and report site level data. So the idea is to reduce frequent site visits and also providing technical assistance through virtual technology. Next slide, please. So after having the conceptual idea on how to implement our solution, we identify DHIS2 tracker is a better solution, which also was also designed and customized to collect KVP and the PrEP individual data records, data remotely, and also which is also synchronized automatically into our project database. Our project database is called PRODMIS, which is called the Project Data Management Information System. Whenever a user is on internet zone, the application will be able to sync whatever data has been collected in a remote site into our central database. The method what we use to implement this solution, we oriented 56 health facility and in Rovuma and Iringa, using both smartphone and laptop, and also we use the modality of online meeting platform such as Zoom and Team to provide the orientation and technical assistance in terms of accessing and using DHIS2 tracker. On my left side, on the left side of the presentation, you'll see that that is a kind of interface. All our data clerk have users and password whereby they'll be able to access this solution. Also, we do have Android capture application, which is in version 2.1. You can download it on Play Store, and also link to our project data through our URL, which is podmis.biosystem.com with your username and password. And then you'll be able to access our interface where you'll be able to send the data. Next slide. The next slide also shows some of the results which we managed to collect through the application. The application was accessed via smartphone and also laptop. These are the results from several councils in Rovuma, like Madaba, Mbinga DC, Namtumbo, Songea, and Tunduru DC. This data was collected from February to April 2020. And we managed to enroll 92 key population clients, which were also reached through this technology. And out of 92 clients, 70 was female sex worker, and 22 were AGY. And also 2 female sex workers were initiated on the PrEP, and 2 tested positive. So the good thing about this DHIS2 tracker is a DHIS platform where also you can do analysis on your data that has been collected. For example, this chart, which is showed the bar graph, was designed to use DHIS2 visualizer, while the bottom table, like a pivot table, were also designed using the event report. Those are the key components that were used to generate all data that was collected during that period of time. Next slide. In conclusion. So in conclusion, all I can say, DHIS2 tracker is a mobile application that helps us to capture, tracker, and report programmatic data during COVID without interrupting our performance that much. And also it's an effective way of collecting site level data remotely on hard-to-reach facility. And also we are planning to expand or to scale up this application solution to other area that we're implementing using the same technology. Thank you for listening. Thank you.
Great. Thank you, Emmanuel. And finally, we've got Albert Ikoje from the SI team at Deloitte, who's going to walk us through our final presentation, and then we'll have questions. Over to you, Albert.
Good morning, good afternoon, everyone. Yeah, I'm happy to share with you our experience on intensive site monitoring and support supervision to improve early retention among clients who are newly initiated on ART. I'll be waiting for the slides to be uploaded. I'm actually working with Emmanuel under USAID Boreshafia program. As Emmanuel mentioned, this is a 5-year program which we are currently have started year 5 of the program, and is implemented in a consortium of 4. Next slide. Of 4 partners, where Deloitte is a prime. I will skip the first 3 slides, as Emmanuel had already made a presentation on those. Maybe just to add that among key partners, they have specific areas that they're implementing, and Deloitte is also overseeing the SI for the program. Next, please. Next slide. Next. Next. Yeah, so I'll go straight on the intensive site monitoring and support supervision. I think this is one of the key components in improving health facilities performance. And as the program itself is focused on improving health service delivery at the health facility level. And since 2016, when the program started, we actually started this initiative in late 2017, where we institutionalized the approach of supporting intensively PEFA priority sites, Tier 1 and Tier 2 sites, where in the program we have a total of 229 among the 618 sites that are currently supported. And the aim of intensifying the site support was to ensure that the SI component is supporting S facilities to improve data verification, providing mentorship and coaching on proper documentation, as well as building the capacity of the healthcare provider in using the data for decision making. Next. So when we were implementing this program, actually the program was ensuring that each facility is equipped with the necessary tools for documenting intervention that the program is doing within those facilities, And each facility was visited at least twice in a month. And the aim was ensuring we are reporting on all the key PEPFAR indicators for ensuring we are easy tracking, detecting, and tracing all the lost to follow-up clients. In this analysis, we did collect the data since October 2017 to December 2019. And this was a cohort of 3 months, quarterly reporting of all new clients who were initiated on treatment during that period. And they were followed up for 6 months, and we managed to observe the outcome through the files that we were tracing and the updates that we had on our database. Those clients who were transferred out during that period were also counted as part of those who were still current on treatment. However, we excluded clients that were they were having a non-status. And we use some trend analysis to determine whether there was any difference over a period of time. Next slide, please. Yeah, so in a total, we had over 87,000 clients who were included in analysis, and you can see that only 360 were left out because they didn't meet the inclusion criteria. And among the analysis that we did in this case, we had a mean age of 35 and standard deviation of around 12 years. You can see that most of the clients that we had this analysis were female in terms of age, about around 62%. And most of the clients were coming from S facilities, and below is also the distribution for each region. Next. So you can see that when we started doing this intervention, our early retention was around 82%. And when we are followed up after 6 months, the retention increased to around 91%. Also, we noticed that after this intensive site monitoring, also loss to follow-up status also reduced from 14% to around 5%, even though there was no difference on the death among new clients on treatment, which remained around 3.5%. The difference was also statistically significant. We noticed that over the period of time for the first 3 quarters of the year, there was no statistical difference in terms of the retention. As you can see, we started around 81, and by July, September 2018, we are still around 81. But and this is because really health facility, they really need support in terms of capacity building, working together, ensuring that we are making that continuity in the support. And after a certain period of time, we started seeing now the improvement where the retention started improving to 84, and then it increased to 91%. And also during this time, we also noted that the retention among male and female was a bit different. And female, they were more likely to be retained as compared to male clients. And this is still an area that we need to improve on, and coming up with some of the innovative ideas on how we can track and retain men into treatment. Next slide, please. Yes. So in concluding, we also find out that through this initiative, and even though this initiative was also implemented in collaboration with the technical team, the regional and council health management teams, as well as the S facilities, we saw that the SI unit or the SI component can play a very key role in ensuring that the facilities, they track and follow up properly the new clients that were initiated on treatment, and through intensive data verification, making sure that the facility, they have the correct data, they are also using the proper data documentation at the facility. This managed them to first to believe on their data, and it really contributed to the improvement in early retention. Thank you.
Great, thank you, Albert. Thank you, Emmanuel, and thank you, Professor Pisa. We're going to go ahead and jump to some Q&A, and Latham's going to walk us through the questions that have been asked on the chat, so please feel free to add to those. I will say that I do appreciate all the presentations. I think that they're a really nice mix of some of the activities that our partners are doing. I think that the broad lines tended to focus on what the technology was used to address a problem, and then the actual intervention that was used to address a problem. So I think those are really nice intros of that. So given the short amount of time, I'm going to turn it over to Latham to ask the questions.
Okay, thank you all. Our first question is from Mackenzie. Her question is for Dr. Pisa. She was asking, how did the innovation result in increases in case finding? Can you talk a little bit more about that?
Thanks. Quick one. So it helped in increase in case finding and new initiations at both facility and community level. And I'll start with the facility level. At the facility level, using the Links app and tool, it helped us to move the counselors to the entry points or the modality point which gave us the best returns for the number of people that are actually tested. For example, for each 10 people that you test in the TB entry, in the PHTC entry or outpatient, they give us different numbers. Those are the different modalities. So you then start rotating your counselors. Instead of managing 8 or 12 entry points at a hospital, they probably need to only focus on 3 or 4 entry points, because that's where you're actually getting the correct yield that you want, actually meet your targets. And at the community level, due to the geolocator that's there on the app. So if people go to the taxi ranks, they go to the farms, into the field, and they do the test on the app, because that data is submitted in real time. You can actually start seeing that, you know what, all your new infections in the month of October are actually coming from this area. So instead of having your community teams going out in a blanket approach, you actually start having targeted community testing and screening that actually gives you more value based on the number of actual tests that you actually do. So that's some of the things that actually help with the case finding. Then I think related to that, you asked the question on power and the challenges of power. And I think to quickly answer that, at a facility level, we did evaluation, and the facilities that we had power outages, and we actually have solar that was installed on those facilities, but we actually also have UPSs working at the facility level. However, for the community testing, what we use with Links is all the testing that happens in the community and the screening. The connectivity is an issue. So what it means that is the person does not have data or is not connected, they cannot submit that data on the knowledge center. However, they can actually do all the entry and the counseling, and when they come back to the facility or to the right to care office, if that device syncs to connectivity, it automatically uploads onto the knowledge center. So that's how the information actually works, activity and no power. Then I think there was one more question that was asked, is when did we actually start this these interventions or innovations. So back in the day, before APACE was called APACE, in South Africa it was called HSS. I think we used to look after 5 districts, not 2. Then the key gap we found when HSS was transitioned to APACE. So we lost 3 districts. So the transition we realized there is that a gap to our programming was that the technical people that are actually doing the programming in the facilities, in the hospitals, the doctors, the nurses, the decision makers on the ground, they did not have access to real-time data on what's actually going on in their facilities. So we get this bunch of targets that we get that we need to achieve in a 12-year period, but we then recompute those targets to a daily target for each facility based on their catchment area, based on the head counts that they've had from the prior year. And we actually realize that, you know what, the more we give the technical teams the data on where they are in terms of progress against their targets, the more they can actually know to where to augment and where to focus on in terms of what they actually need to do. So we realize that, you know what, if we wait to only see our data at the end of the quarter when we're doing data submission, and you realize that, you know what, your performance is actually 20% against the target, there is not much more I can do at the end of a 4-month period because it's gone already. But if we can monitor on a daily and a weekly basis and have interactions with USAID and the Department of Health, we all are aware, no one is surprised. Back in the day, USAID is surprised that guys, you're not performing. But no one is surprised now. We know the challenges. We help each other to make sure that we're trying things that work. We remove the things that don't work together as a team. And that has really worked well. So I think that's the key thing of having everyone on the table. Another thing we realized as the last point is that when we got together, DOH, the implementing partner, and USAID at times, instead of talking about the interventions that we actually need to talk about to improve patient outcomes and care and targets, we're actually arguing about the numbers. Where I'm like, no, we did not initiate 10, we initiated 20. And the other guys are saying, no, but those are not our numbers. And the other guys are saying, but that's what you submitted. Then we spend more time arguing about the numbers, but now we're all looking at the same numbers, same dashboards. It's more about the interventions than arguing about the numbers. But also we use these tools as a way of sanitizing what's on data, high frequency reporting, our daily submissions on the Google Sheet to USAID, plus also the DHIS tool, right? And our funders, they've got the changes all the time to the reporting, and there's cumbersome reporting. Without automation, you'll find yourself doing Excel spreadsheets the whole month to meet the reporting requirements, and automation facilitates that efficiency. I'll pause there.
Thank you, Dr. Pisa. We have to wrap up. Maybe just time for one more really quick question for Emmanuel. Just wondering how your mobile program was integrated with PEPFAR reporting requirements. We have only about 2 minutes, but if you could just touch on that very quickly, we'd appreciate it.
Yeah, our program was implemented using the PEPFAR requirements, especially in terms of KVP enrollment. We take into consideration all the indicators that are required to be reported under PEPFAR. And so all the data that was collected was based on the indicator that is being reported under PEPFAR. And also, I think I've seen a question from Bartolomeo with regard to power situation on the use of mobile tablet for data collection. How do we cope with the power situation? As I explained, that the interface the application is accessible via a smartphone or tablets and also laptop. In a worst situation where there's a power outage, Well, of course, due to funding limit, we are intending maybe to have a solar backpack if the funding is allowing, so that we maybe cope with the power situation. Thank you.
Great. Thank you very much, everyone. I want to again thank our three presenters for these nice presentations. We are going to have to call time right now, so people have time to go to the next session. The emails for our presenters will be available to the participants at the end of the conference. So if you do have questions specifically about some of the activities that they undertook or some of the challenges that are pertinent to your own situation, you will be able to get in contact with them. So again, I just want to thank Professor Pisa, Emmanuel Mpinga, and Albert Ikonje from Right to Care, FHI 360, and Deloitte, respectively. Thank you again. We enjoyed this, and I hope everyone has a nice day.
Thank you very much.
Thank you.
Thank you.